Good evening, everybody, and you're very welcome to our webinar on living well with cardiovascular disease. My name is Irene Gibson, and I'm a cardiovascular nurse specialist with Croí, the West of Ireland Cardiac and Stroke Foundation, and I'm delighted to be chairing tonight's session, which is brought to you by Croí and has been supported by Sláinte Care. So as a heart and stroke charity, we'd normally be delivering information and public information sessions like this face-to-face in our dedicated heart and stroke centre in Galway, or out in various locations and communities across the west of Ireland. However, due to the pandemic, we've had to shift all of our support and public awareness sessions online. However, hopefully this won't be for too much longer given the positive announcements this evening. So the aim of tonight's webinar is really to address your questions, priorities and concerns related to your heart health. The format tonight is very informal. We'll be working through a series of questions that have already been submitted to us over the past week and through questions that hopefully you're going to submit online tonight. And I'm going to talk to you a little bit about how you do that. We really would welcome your participation in the session tonight. On the bottom of your screen, you'll see a number of tabs. So you'll see a chat function and you'll see a Q&A function. So just type your questions in there as we go and I'll put them to our guest panel tonight. We also have one or two polls that we're going to use tonight, and that's really just to keep the session engaging and interactive as well. So we're going to get started, and without further ado, I'd like to introduce you to our panel this evening. So in no particular order, our first guest panel this evening is Dr. Jim Crowley. Jim is a consultant cardiologist at University Hospital Galway. He's also the research and medical director of Croí. So you're very welcome, Jim. We also have Aisling Harris. Aisling is a cardiac specialist dietitian who is based in Croí. And we also have Dr. Cathy McHugh, who's a consultant endocrinologist who is joining us from Sligo University Hospital. You're all very welcome this evening, and thank you for taking the time to join us. So we're going to kick start, and Jim, I might begin with you. And what I'd like to do is maybe talk a little bit about why you think it's important for people to live well with cardiovascular disease, and what does that mean?
Thanks very much, Irene, and thanks for inviting me to this discussion. I think it's going to be very interesting. Heart disease, I suppose the first thing about heart disease is it remains the most common cause of death across Ireland and indeed across Europe today. And if you look at incidence of heart and stroke, we account for about 35% of all deaths in Ireland today. And second to us is cancer, and the third biggest cause would be respiratory disease. So heart disease remains a very important cause of death and something that we can significantly reduce by addressing the risk factors. We talk about risk factors, and these are factors that we have identified through research over many years that we know are strongly associated with the development of heart disease and stroke. And we also know that if you look at these risk factors and you compare the incidence of these risk factors or the incidence of heart disease in countries that have high incidence versus low incidence, you can account for a lot of that difference when you look at the incidence of these risk factors. So we know that things like high blood pressure, high cholesterol, being overweight, particular types of diet, and cigarette smoking habits and so on account for the vast difference, for the vast majority of difference between the mortality rates in high incidence countries and low incidence countries. So we also know that after patients have had heart attacks, many will, or a certain number, up to 20% of these will present with further heart attacks within a year of having had their first event. And we know that if you reduce the risk factors in these individuals or reduce the levels of blood pressure and cholesterol, change dietary habits, cigarette smoking, and so on, if you do that, you can significantly reduce the risk that they will have a heart attack within the first year. So that's probably the context of all of this and why we emphasize management of these risk factors so much.
That's great, Jim. And of course, when it comes to managing risk factors, when somebody has an event, often they're confronted with probably having to make lots of changes to their lifestyle and looking at controlling these different risk factors like cholesterol and blood pressure. And that can be somewhat overwhelming for people. And sometimes people you know, some of the questions that we got in for tonight were questions regarding maybe struggling with motivation levels, and also looking at, you know, how do they prioritize what changes to make and when. So maybe, Aisling, I might move to you in terms of, as a dietitian, if you could maybe offer some advice for people who are struggling to get motivated in terms of making lifestyle changes.
Yeah, it's a great question, and something that we see so often, maybe immediately after an event, making all these changes, trying to aim for this perfect diet, perfect lifestyle, and then over time, maybe losing the bit of motivation and maybe kind of slipping back into old habits. So what I would suggest is, instead of trying to take on so many things at once and aim for perfection, is to, you know, pick 2 or 3 very specific goals, focus on something you want to achieve. So maybe you're focusing on lower your blood pressure or your cholesterol. Look at how much salt is in your diet. You know, are you adding salt to your foods? Are you reading food labels to look at how much added salt is in food? You know, if you're looking to lower your cholesterol, could you reduce the butter on your bread in the morning? Could you add an extra portion of oily fish, an extra portion of fruit in the day? So making your goals really specific, not taking on too many things all at once, and, you know, writing down these goals and writing down why you're doing them, why it's important for you to have your cholesterol under control, your blood pressure under control, manage your weight. Have that written down somewhere that you can go back to and remind yourself why you're doing it, if you are struggling with the motivation long term.
That's really practical advice, Aisling. And of course, it's also important for people to attend cardiac rehabilitation programs.
Hugely. And we've started doing our virtual cardiac rehab mice launcher program. We've had really good uptake. We're seeing really good results. It's so important after your event to make sure that you do uptake one of these if they're available to you, and you'll get the diet, the lifestyle, the physical activity input that's so important after you've had an event.
Great, thank you, Aisling. Cathy, we got a lot of questions in relation to the link between diabetes and heart disease. Could you explain to us a little bit more about what that link is?
Like you can regard them as, I suppose, flip sides of the same coin. It's the same type of person and the same risk factors and the same lifestyle factors, such as being overweight, such as not eating healthily, that puts you at risk of cardiovascular disease, smoking, all those things. They're the same risk factors that put you at risk of getting diabetes. Now, having said that, having diabetes does not guarantee you have heart disease. If you control your diabetes and you lose your weight and you exercise, you can bring back your risks. But as you get older, you clearly have risks. But the important thing is that one does not necessarily equal the other, and it's not that you get diabetes, therefore, you know, the ship has sailed. You can reverse and you can lower the risks if you work on your diabetes. And diabetes is not purely about sugars. I think historically diabetes doctors looked at sugars. Whereas now when someone comes to see me, I'm looking at blood pressure, waist circumference, weight, exercise, diet, all of those common sense, very basic things. And they're the very things that none of us really want to hear. You come to me and I'm not going to give you a magic pill to sort the whole kit and caboodle. You gotta put in, you gotta run, you walk, exercise, eat properly. It is a grind, but that is what will sort this. It's not a magic pill. So the link between them, diabetes is a cardiovascular illness predominantly. It's not just about sugars, and one does equal the other, but does not have to equal the other. But it's the same kind of person who tends to get the two.
That's really insightful, Cathy. And you mentioned about reversing diabetes. How does one reverse their diabetes?
Now, it depends what type of diabetes you have, and I would separate your type 1 diabetes from your type 2 diabetes. But if I was to look at type 2, which would be, I suppose, the commonest, it's the weight. It's the weight that is the biggest issue. It's the lack of exercise, the poor diet. They're the things that lead you down the diabetic line in the first place. And they're the things that if you reverse, you can retract down that pathway not easily. It's not an easy thing to do, but it can be done. You may never get rid of it completely, but just certainly can go from being on insulin to being on diet and all that. If there's less of you physically in terms of weight, you can significantly reduce your diabetes, how bad your diabetes is, and perhaps even whether it is there or not. So it's that message, it's that healthy lifestyle. It's in your hands, but it's a grind. There's no point saying it's easy.
But I think the message here, though, Cathy, is one of encouragement in terms of what people can do to reduce their risk of developing diabetes in the first place. And then if they have been diagnosed with diabetes, there is a lot you can do to control it.
Absolutely. I would say you need to control your diabetes. You do not let it control you. It needs to fit in. While you need a healthy lifestyle, we all do, diabetes or otherwise. And it's the same advice applies to all of us. We all need to exercise. They recommend at least half an hour a day. They recommend the kind of exercise, if they say if you're walking and you can talk when you're walking, you're not walking fast enough. So I'm not talking about a stroll with a dog who has 3-inch legs, for 15 minutes a day. I'm talking about a proper exercise. That proper exercise can reverse the diabetes. It certainly can. If you have already diabetes, that proper exercise, the diet, taking your tablets, attending your appointments can help you manage that diabetes. And then you therefore don't run into those cardiovascular risks in the first place. I would very strongly say it's in your hands. It is an illness that you can control, and it is what you make it, very much so, which is both good insofar as you control it, but bad insofar as you've got to work it.
Cathy, you mentioned about the importance of looking after your risk factors and how to control diabetes. Are there specific programs that you would recommend for people in cardiovascular disease? We've got programs called cardiac rehab, but for diabetes, are there any similar programs?
There are programs. The MEDEX would be one that we would use here, which is an exercise rehabilitation program after people are diagnosed with type 2 diabetes. They would be there definitely are programs like that out in the community. There's different programs. There's Desmond, which is an educational program for people with diabetes. Absolutely excellent, but it's largely educational. They won't have you out running the street. It provides you the tools. I would say stuff like Weight Watchers. I would say Unislim. I don't want to pick one over another. Any one of them is a program for diabetes. Any one of them is excellent, and the reputations of them and the long-term weight loss is excellent in any one of them. But there are programs locally. It's worth speaking to your practice nurse, your diabetes nurse, your GP, and finding something that's accessible to you in the community. And it may not suit everybody. It depends where you live. It depends what age you are. I know we would have a lot of people that would have taken up the program here in Sligo. And actually, now it's obviously pre-COVID, a little community has developed. There's a group of about 10 people that go on I would say a Tuesday afternoon and 10 on a Wednesday. And they've become quite a little group. They go over to the gym and the IT, and then they go for coffee. Well, they did go for coffee afterwards. And it's a lovely, lovely program. And it encourages each other. And you make this, it's from a friendship point of view, it's lovely. It's also, there's a socialization around it and a normalization. A lot of them would then go for walks in the woods or do things like that after it. There are some lovely things out there, but it differs from area to area. So it's worth making the inquiries to what's available locally to you and how much they cost. The vast majority are free, I must say, but it's worth inquiring.
Great. So chatting to your practice nurse or GP, and hopefully they should put you on the right path. Now I'm going to go to the Q&A box at the bottom of the screen, and we've had lots of questions in. The first question here is about what's the best way of lowering blood pressure. So Jim, I'm going to go to you first, and then I'm going to follow up with Aisling, because I think there's going to be two different approaches to this that are very complementary.
Yeah, well, I think all methods, anything that works obviously works, but we would always advocate lifestyle measures first. Now, quite frequently, drug therapy is required, and quite often multiple drugs are required for adequate control of blood pressure. And in certain groups of patients, we recommend more stricter regimes, and I'm sure Cathy will talk about diabetes than in other groups, but I would always advocate lifestyle measures. So you will hear the same theme, I think, throughout the talk, talking about exercise, weight, and dietary measures for helping to reduce blood pressure in the first instance. But after that, then we're looking at drug therapies, usually in addition to all of these methods, and they are obviously an important adjunct. And the fact, there's a couple of things I suppose about blood pressure when we get onto tablets, is that some patients get worried when they need 2 or 3 or 4 different types of drugs to control the blood pressure. This frequently does not mean that the blood pressure is particularly high. It just often means that the patient, for whatever reason, the tablets are only moderately successful, and they require the addition of multiple different medications to get it under adequate control. I think it's important in many patients then to treat to a target value, to try to get to the value that is recommended by the different guidelines, because we know that when you get to these values, it does produce added benefit in terms of reducing mortality, particularly from stroke, but also heart attack and other things.
Jim, you mentioned about targets. What should one's blood pressure be?
Well, it depends really. You know, if you are older, it gets more difficult to control blood pressure. Younger patients, if you have diabetes, we tend to be a bit more strict. But you know, if you're under the age of 60, a target of 140/90 is perfectly reasonable. And but you know, sometimes in type 1 diabetes, we want to be down to around 130/80 if possible. Now, sometimes these figures are very difficult to achieve. So what we try to do is to get as close as possible. And you always have to balance the possible side effects from drug therapies, for example, against the net gain. And you always try to find a cause, even though with the vast majority of patients, we will not find a cause for high blood pressure. A specific cause, I should say. We may often find that they're overweight, for example, which is a common thing. But there are other things. For example, I had a patient only 2 weeks ago who had chronic pain from back injury, and their blood pressure went up as soon as they developed the back injury. And the problem was the pain rather than the blood pressure. And once we got that sorted, it was much easier to control blood pressure. But you know, it's often very difficult to find a cause, and it often does require drug therapy. But lifestyle measures are always important at the beginning.
So less than 140/90 for the general population. If you've type 1 diabetes, your targets may be lower. And if you have heart disease, are your targets lower?
Yeah, well, again,
140/90?
Yeah, again, we try to get down to 130/80 or sometimes even 120/80. But again, it can be very difficult to get down to these values in patients who've had heart disease, in any patients. But yes, yeah, we try to get it down to 130/80.
Aisling, could I just ask you about lifestyle changes to reduce blood pressure, but specifically maybe diet?
So yeah, lifestyle measures are hugely important. I suppose with diet, the biggest one will obviously be your salt intake. And it's not even just about the salt that's added at the table. That is just purely extra on top of what we're having. Most of the salt that we actually eat is found in our food already, in processed foods. Anything that has a package, it's there to preserve the shelf life. It's also there to make things taste better. Gets on our taste buds. So reducing salt be a big one. Weight reduction, again, if you lose only about 5 to 10% of your initial body weight, you'll have reductions in blood pressure. Exercise, again, reductions in blood pressure immediately after a session. Another thing with diet is fruit and vegetables, specifically fruits with potassium, can help balance the sodium, so it can help lower blood pressure. But the big one is salt. So we shouldn't be having more than about 5 grams of salt a day, which is about a teaspoon. Might be even less if you already have high blood pressure, might be 3 grams a day. The average intake in Ireland is about 9 grams of salt, and that could be found in one takeaway. So reducing salt is probably the single biggest dietary change you could make. And that would hugely be helped by reading food labels. So foods that you would never think contain high levels of salt actually are quite significant contributors to salt in their diet.
And on that, Aisling, I think you've lined up our first poll for the evening, where we're going to engage the audience.
Interesting one. So hopefully we can share it.
It's coming here, yeah. Or, sorry. So it's the hidden salts one, Aisling, is it? Yes.
Yep, that's it.
Yeah. Here we go.
Perfect. So you can probably see it on screen there, but which of the following foods has the highest amount of salt per serving? So would it be a packet of salt and vinegar crisps, 5 chocolate digestive biscuits, or a cup of soup? So powdered soup that you add water to. So guess which one would have the highest amount of salt?
So we'll give everybody maybe just 10 seconds. We want a quick response to this one.
So I know when I first saw this, I was pretty shocked.
It's a tricky one, Aisling.
Mm-hmm.
How are we doing, Annie? And Annie's our coordinator this evening. She's on our backroom team, keeping us all in line.
Yeah, we're okay. We can end the polling now, Aisling.
Lovely.
Yeah,
can you
yeah,
see
you can
that?
enter
Yeah,
now.
you can see
Yeah.
that. Yeah. So the winner on this end appears to be at 70% the cup of soup.
Mm-hmm. Yep. So I can give you the breakdown of what's in each of them. So the cup of soup has 1.3 grams per serving. So just a little cup of soup with added water. Okay, yeah, you actually got it right. The people clearly listen to my talks. The 5 digestive biscuits actually has 1 gram of salt, and the salt and vinegar crisps, which has salt in the name, is 0.8 grams. So like things, I think the biscuits, you'd never expect them to be salty until then you see this and you go and taste them. They do taste salty. So if you had all 3 of these in a day, you've got 3.1 grams out of your 5 grams of salt a day. So well over half. That's before you've had any of your main meals or added any salt to your food. So reading food labels is so important, and watching these processed foods.
Wow. Thanks, Aisling. That's really surprising in many ways. And of course, Croí and the dietitians of Croí have developed a really nice food label card, which is actually available on our website for those of you who are interested in learning more about the content. Oh, lovely. Aisling is showing it there on the screen. Yeah. So it's basically putting a traffic light on every food to help you make the right food choices when you're shopping.
Mm-hmm. Such a valuable skill. And in our HeartLink West series, if people want, we'll give the details at the end. We give a session every couple of weeks about how to read the food labels. So that could be one for people to hop on after.
Lovely. And HeartLink West, for those of you who aren't aware of what it is, it's basically a dedicated telephone support line that's offered to members of the public or people who are concerned about their heart health, or concerned about stroke, or living with any of these conditions. And as part of the support service, in addition to the telephone support helpline, there are a whole series of weekly virtual chats that Aisling and the team in Croí do. So we can give you more details on that towards the end of the webinar. I'm going to move on now. And Jim, we've had a couple of questions in that are very, I suppose, COVID specific, if it's okay. And the first one is I have ongoing left-sided chest pain after COVID-19. It's a dull ache, but my GP said it should be okay. What should I do? Now, what's not clear here is whether the person has a diagnosis of heart disease, or that they've just had COVID and have no underlying conditions.
Yeah, well, ongoing chest pain is a relatively common symptom after you've had COVID, and it's probably one of the, we talk about this long COVID syndrome. We don't really know what it is, but it sounds like a post-viral syndrome that some people will get after they've had COVID, and chest pain is one of the common features of that. It is important, I think, to assess it like you would assess any other patient who has chest pain. And if it has features that are suggestive of angina, i.e. if it's related to exercise and relief by rest, then it may need to be investigated further. But it is quite common for patients after they've had COVID to experience some form of chest pain, probably up to 20% of people. Again, if they haven't had heart disease in the past, again, it really depends on the features. Generally speaking, we look at the features of the type of chest pain that the patient describes, and then look at that in the context of what risk factors they have for developing heart disease. And that's how we evaluate that. Then after that, if we think that there's a significant chance of heart disease, we may look at investigations such as exercise testing or coronary angiography if necessary. So I'd need to know a little bit more about it. I suspect that this is a pain that's related to the COVID, and that as time goes by will improve. But, we have to look at it in that context.
Great. And just following on from that question in relation to the vaccinations. So this person has a history of atrial fibrillation. They're taking blood thinning medications. However, they're concerned about the vaccine and clotting. Would you have any advice or recommendations, Jim?
Well, in terms of atrial fibrillation, actually, because they have atrial fibrillation, their risk of having a more severe form of COVID, should they ever get it, is increased significantly. So it would be more important for them to be vaccinated to ensure that, to reduce the risk of getting the disease in the first place. this risk of clotting in patients with atrial fibrillation. First of all, your risk of clotting, generally speaking, will be significantly reduced because you're taking an oral anticoagulant. There is no evidence, and to my knowledge, it hasn't specifically been looked at, that you would be at increased risk of clotting just because you had atrial fibrillation if you had COVID. The general advice here would be that the risk of COVID causing mortality is so much higher than any risk from the vaccine that the strong advice would be to take the vaccine regardless of type.
Thanks, Jim. And I think that, you know, a lot of people are worried about the vaccine, but I think it's really important to get that perspective on things in terms of, you know, the risks and the benefits and so on. Cathy, the next question I'm going to put to you, and I think it's a really important question and probably not something that's discussed enough. This question comes in from somebody who's got type 2 diabetes. They've had a heart attack with 2 stents. However, since then, they've developed erectile dysfunction. Is it the medication or my medical history the person wants to know? So maybe first of all, it might be helpful just to talk a little bit about what erectile dysfunction is. Is it common? And maybe then if you could clarify whether it could be medication related and other causes.
Okay, I think it's something that we don't speak about enough. It's an extremely common condition, and it's one that people are embarrassed about, and therefore they're afraid to ask their GP. They're afraid to mention to people. As you get older, there's an increasing incidence of it. I would say I wouldn't accept it as part of getting old. It's something we can do something about. Often it's just nothing at all, and all it needs is a little bit of reassurance. And just to get over the blip, and then you're fine. What it is basically a failure to get an erection enough for penetration. That's what it is. And it can come in all kinds of different forms. In terms of somebody who's had a heart attack or had stents, there are medications that can exacerbate it. It's worth having a look with your GP what ones you're on, because some are better than others at doing that, or worse than others, wherever you want to look at it. And it may not be that at all. You'll often find that it's just the fact that you've had a heart attack. It's just shot your confidence. And all you need is for it to not work once. And then the next time, oh my God, the panic overtakes and it won't work the next time. And you get in this spiral. So sometimes it's just nothing, and it's easy to sort with a bit of reassurance. It's worth looking at the medicines. There are certain medicines that do it worse than others, but there's certain medicines that you can't, like nitrates, which are ones we use for angina, that you can't use the Viagras and the Cialises of this world with. So it is an important conversation to have. There are medications you can use to deal with it. The Viagra would be the most famous one, and it's now available over the counter. So it takes away some of that embarrassment of going to the GP. But I suppose you're going to have to say it to the pharmacist. You're going to have to say it to somebody. I think as health professions, we should ask the question more. I think if you ask it as part of your routine, it's as common as asking you, I don't know, anything, have you chest pain? Then the patient becomes more comfortable saying, if I'm comfortable with it, they'll be comfortable with it. If I'm feeling awkward about it, then understandably they'll feel awkward about it. But as a doctor, and maybe as a woman, maybe this is the wrong thing to say, one organ is the same as the next. I don't feel remotely embarrassed when somebody says it to me. Some men will tell you that it's difficult to say to a man. Some will tell you it's difficult to say to a woman. I feel my job is to ask. And if I ask enough, and if every time someone comes to see me, they know they're going to get asked that question, it becomes the most normal question in the world. And at some point, they will feel like answering it properly to me if it's an issue. But I am telepathic. If you don't tell me, I don't know. So it is really, really important to communicate. And by putting you on by reassuring you, be looking at your medication, putting you on tablets specifically for it, or failing that, there's others, injections and all kinds of other little bits and pieces we can do. This is something we can sort. Another, on a slightly aside from that, I would say it's a really good marker of cardiovascular health. If you're getting this problem, you need to go to your doctor for a full MOT. Or an NCT, whatever you want to call it. You need to look at your general health. It's a good marker. Don't take it as an isolated standalone or not standing alone event. It needs looking at. But it actually, you'd be surprised how easy it is to fix it. The most difficult part is probably having the conversation in the first place.
Cathy, that's really reassuring, and thank you for giving that insight. And you're right, as healthcare professionals, we don't discuss this topic enough. Jim, did you want to come in there?
Yeah, I just wanted to say one thing. I agree with Cathy on all of that, and I think it's very important that you know, the one thing that we also don't discuss very well is patients who have had heart attacks or stents, or have just been told that they've had a cardiac condition, that they frequently experience some degree of depression after they go home, particularly amongst men, in my experience anyway. And this may, you know, overlap with difficulties with erection and so forth. And it is important and I think that's why things like cardiac rehabilitation can be very important, because they instill this confidence and motivation to get back to normal activity. Because in the end of the day, after you've had a heart attack, the goal is to get back to entirely normal activity for the vast majority of patients in every aspect of their lives. And sometimes that's not possible, but that is the goal. And some people come up against this wall when they've had a heart attack and feel and become quite depressed, or even not even severely depressed, and they won't even recognize it within themselves. And it is very important, I think, to get them to realize that the goal is, in one sense, to put the heart attack behind them and to get on with their lives. So, you know, this is overlapping with erectile dysfunction. Sometimes that can be one of the causes, as well as the tablets and so on.
So keeping the lines of communication open, talking to your healthcare professional, attending cardiac rehab, and even just chatting to your family about your emotions. I mean, it's all part of the recovery process, as you said, and very important in terms of living well with your condition. A lot of questions have come in terms of follow-up, Jim. So one question here in the chat is, when you have 6 stents in situ, is it recommended to have them checked over time?
Well, you know, this is a very good question, and it's something that comes across, that we come across all the time. I mean, we are in large part, we are driven by symptoms, actually. So if a patient comes in with symptoms suggestive of angina, they end up, you know, after a number of investigations, they may end up having a coronary angiogram, and if they have a blockage, they end up having a stent put in. And after that, hopefully the symptoms will improve, and then we look at risk factor modification and lifestyle changes and possibly drug therapies and so on. What we're not really good at, and what we really don't know, is how can we evaluate these stents, and when should we evaluate these stents after they have been put in. The vast majority of patients who have stents put in, there are no difficulties, but there are a significant proportion who will develop, the small proportion will develop narrowings within the stents, but also there's another group of, the same group of individuals may well develop narrowings at a site other than the site where the stent was put in, as part of the disease process that's there. So how do we evaluate those patients? Should we do exercise tests on a yearly basis? Should we do them every 2 to 3 years? It's not very clear what the best answer is, because often after a patient has had a heart attack, or after they've had stents put in, exercise tests are often not quite as good at discriminating between people who do not have heart disease and those who do have heart disease. So a lot of it is driven by symptoms. Now, having said that, we are fairly quick to go back and do a repeat angiogram if there is even the hint of symptoms suggestive of angina. But if patients have no symptoms, we tend not to go back on a routine basis to evaluate patients by coronary angiography. The number really isn't important, and often frequently when patients come back and represent, it's not the stent that's the problem, it's that they've developed narrowing elsewhere in the coronary anatomy.
Thanks, Jim. I'm going to move on to some dietary related questions now, Aisling. So the first one here is, what are the worst foods for your heart? And is there such a thing as a bad food?
Good question. I like to say that no foods are bad once they're in moderation, but the biggest one, I suppose, would be salt for blood pressure, which we've discussed earlier. The next biggest one, I would say, and it's probably the one I find most difficult to change people's opinions on, is butter. It's really high in saturated fat, contributes to the high cholesterol levels, and it can cause that plaque buildup that we've been talking about. So salt, butter, processed meats, so much evidence coming out now about how bad processed meats, so like rashers, sausages, salami, chorizo, ham, high in salt, high in saturated fat, not very, they're also linked to bowel cancers. And then obviously with salt and fat intake all combined, it's probably the ultra processed foods, anything that's been reformulated, extra salt, extra sugar, extra fat, extra chemicals added. Good example is, you've got your chicken breast and you've got your chicken nuggets. So you've got your lovely lean, high protein chicken breast, no salt, nothing. And then you've got your chicken nugget, which is the chicken, the skin, the tendons, added salt, added preservatives. So you've taken a good, healthy whole food and ultra processed it with all these nasty additives. So in terms of good and bad foods, the bad foods are the ones that are high in salt, saturated fat, the ultra processed ones.
So what do you recommend, Aisling?
Good question. That's probably the one I get asked most. What can I eat? And for that, the overarching advice would be a Mediterranean style diet. Now, what is that? It is what they probably would have eaten in, Italy, Greece, Cyprus back in the 50s. Lots of fish, lots of fruit and vegetables, olive oil, nuts, seeds, whole grains, moderate amount of alcohol, enjoyed in lovely sunny countries. So how do we do that here is the next question I get asked. And it's taking bits of that diet. So in Ireland specifically, less butter, more olive oil, less red meat, more fish, more oily fish, switching from white bread, pasta to the whole grain version. So an overall diet that's good for heart health and good for everyone would be your Mediterranean style diet in a nutshell.
Excellent, excellent. Then in terms of just looking at, I suppose, lowering things like cholesterol and blood pressure, and again, some people have come in with some questions here in the chat around cholesterol. Is there any one type of food that you would recommend for lowering cholesterol?
Yep, so with cholesterol, there's foods you can reduce, and then there's foods that you can increase. So the foods to reduce would be butter, red meat or fatty meats, fatty cuts of meat like chicken wing, pork belly, pork, high fat mince, cheese, butter, obviously your takeaways, your pastries, your buns, all those nice things. Basically reduce them as much as possible. It's not saying they have to be cut out, it's just looking at how often we have them. And then other foods you can actually eat that will help lower cholesterol would be things like porridge, beans, lentils, legumes, something again which we don't eat much of in Ireland, but they can help soak up some of the fat from our diet and can help lower cholesterol. Other foods that people can have would be like your plant stanol, plant sterol drinks. So you've got your Benecol, your Flora Proactive, Aldi and Lidl have their own versions. One of those drinks a day can help lower your cholesterol as well. It's the same component in them that is found in plants. So if you have a higher plant and fruit and vegetable diet, you'll get that same benefit.
And Aisling, there's lots of those products. So are you specifically talking about the drinks? I mean, how about the spreads and any of the other products?
The drinks are handy because you will get the dose that's needed to lower cholesterol in one drink. There are milks and there are spreads and there are yogurts. With the spread, you'll have to be having about 12 grams a day, which is kind of 3 or 4 teaspoons to get the benefits. So cost per value is probably the spreads are more expensive. They're still fine to have, but if you want to get the cholesterol lowering effect, one drink or one yogurt is good for the day, but you do need to keep taking them to see the benefit. You can't take them for a while and then stop. You need to keep taking them.
And of course, there are different types of cholesterol. So should we go to our next poll for the evening? So Annie, if you could work your magic. So we have a question for the audience.
Perfect. Here we go.
Yeah. And it's on LDL cholesterol. And of course, the LDL cholesterol, that's the bad cholesterol, Aisling.
Yes,
See
so
that?
the LDL cholesterol.
Yes,
Yep.
Thanks, Annie. So I've had a heart attack. What should my LDL cholesterol be? So should it be less than 3 millimoles, less than 1.8 millimoles, or less than 1.4 millimoles? We'll give you a couple of seconds. So while we're waiting for people to respond there, Aisling, with the good cholesterol then, are there foods that improve your good cholesterol? Because your good cholesterol is your HDL.
Yep, so your HDL, you can raise that by having more of these good types of fats. So when we talk about fats, typically people would have thought that a low-fat diet was heart healthy, but we know now that that's not the case. High levels of these good healthy fats are what's important. So
great. So we
good.
just have our results coming in. I feel like we're on the Eurovision Song Contest. So we have a very well-informed audience tonight, I must say. So 43% said less than 1.4, 29% less than 1.8, and 27% said less than 3. And yes, the majority are right. It should be less than 1.4. Of course, that's a difficult target to achieve for many people, Jim.
Yes, it is. And again, dietary measures, exercise, all of those things we talk about are the first line. But it's very, very common for patients to be put on drug therapies, particularly after they've had a heart attack, to try to get down to those very low levels. Before we had the statin drugs, we would never have been able to get those low levels. With statin therapy, we can do it, but it requires dietary measures as well, of course. And there are some newer agents as well which are helpful, but it really is down to the statins as the major form of drug therapy for these patients.
And Jim, is that statin therapy for life? And I suppose just in general, there are lots of questions coming in here on the chat wondering about, if you're put on medications after your event, are they generally for life? So you might comment on that as well.
Yeah, a lot of the drugs that we put patients on after they've had a heart attack are designed really to reduce the risk of having a further heart attack in the future, and they are often for life. So aspirin is a common agent. And often they're put on cholesterol-lowering drugs, usually because if you stop the drugs, after a few months, the cholesterol levels will tend to rise again. So they tend to be on cholesterol-lowering drugs. There are other drugs as well that we use, so-called ACE inhibitors, which we recommend for certain groups of patients, particularly if their heart function is reduced, because we know that these reduce the mortality in the long run. In general, most of the drugs that patients are put on after they've had a heart attack are for life. The exception might be when a patient has had a stent put in, or even if they haven't had one, if they've had an acute heart attack, we put them on what's called dual antiplatelet therapy, aspirin and another antiplatelet agent such as clopidogrel or prasugrel or ticagrelor. This agent is usually just for 1 year after the stent or after the patient's had a heart attack, and then they go back to the aspirin therapy.
Thanks, Jim. Cathy, question for you. Is Viagra safe to take with heart failure? I know you spoke about some of these medications and if people are taking nitrates, but if somebody has a diagnosis of heart failure.
Yeah, assuming that they're physically fit enough. Now it depends how physically healthy or unhealthy. Having said that, they say that if you can climb a set of stairs, you're fine to have sexual activity. On that basis, the Viagra is safe in that population. You just be careful of the interactions with the drugs, the medications. Other than that, absolutely, I would have no issue with it. What I would do is, if you're thinking about it, I would have a chat with your GP just about the physical exertion of it, and have a chat with your GP. But in general, it's absolutely safe. And in actual fact, people, you will find if you look at the studies, the people who would have regular sexual activity would actually live longer. And whether or not that you're healthier and you're doing it and you're happier, I don't know. But I would certainly think that it's not a reason not to by any manner or means. And it's something like Viagra can be very helpful with that. But I would, on the proviso that just watch the drugs, speak to your GP or your pharmacist to make sure that everything else is okay for you to do that. By all means do.
Excellent. Another question, Cathy, for you is for somebody who has diabetes and they had a subarachnoid hemorrhage last week. They always had their diabetes under control and they would be a very active person and very disciplined with their diet and exercise. They're back to exercising in the last few months, but their diabetes is out of control and their meds have been doubled. And they're just wondering if there's a link between the hemorrhage and their poor diabetes control at the moment.
Insofar as does having a hemorrhage mean that your control goes out of sync? No. What it probably does do is confine you to the bed or the hospital. You're therefore not eating like you normally eat. Maybe they're stopping you some medications to do this test, that test, the other test. And they also, I suppose, are limiting how much exercise you take. All those kind of things will make your control worse. If your control was good coming into this, your control would be good when you get home, when you get back to yourself coming out of this. And in actual fact, in terms of your whole cardiovascular health, it is beneficial. I would think it's probably a temporary blip. I think there's nothing quite like going into hospital to send your diabetes into orbit. And you're then eating different food at different times, and people are bringing you grapes and Lucozade and all the stuff they bring you in hospital, which you just do not need. So I would think it's probably the inactivity, the hospitalization and the illness, rather than the fact that subarachnoid hemorrhages cause the diabetes to go out of control. If you had control coming into it, you'll have control coming out of it.
Okay, that's good. Jim, I'm going to come back to you on the next question. So how does one monitor a trivial leakage of mitral valve? As a 49-year-old fit, healthy, non-smoker, low cholesterol, I often wonder if the situation could be getting progressively worse without knowledge. Are frequent scans, echoes required? And it looks like this person has a family history of heart disease.
Yeah, well, first of all, mitral valve disease is generally speaking not related to coronary artery disease. They're two separate entities. Mitral valve disease, so the mitral valve is one of the valves of the heart which can leak as time goes by in some patients. A trivial mitral valve leak, it's likely that this will not progress. If it does progress and it becomes like a mild or a moderate leak, then we would tend to follow that up with echocardiograms, depending on the patient, but it's frequently no more than an echo every 3 years or so would be sufficient, unless the valve actually shows signs of deterioration. A mitral valve, when it starts to leak, it tends to be a very slow progressive, very slow process. And like I said, in many patients, it doesn't progress at all, particularly a trivial leak. A trivial leak is quite a common finding in patients who have echocardiography. So when we're doing the echo, we look at the structure of the valve, we look at the size of the chambers, and so we can get added information to give us a hint whether this is going to progress or not. But like I said, if it's trivial, it's probably never going to progress. It may be no harm. I would recommend to have a repeat echocardiogram in about 5 or 6 years' time if it's trivial at this point.
Okay. We've also had lots of questions in the chat about people who have a family history of heart disease and concerned about their own risks. So for example, this lady's asking, her father recently passed away from vascular dementia. She is nearly 50, overweight, blood pressure just normal, underactive thyroid, menopause, but not on HRT medication and trying to lose weight. What more can the person do, or is there anything that they should be doing, or any screening as well that they should be looking into?
So this is a patient who is somewhat overweight,
who has a family history.
And a family history.
Yeah, of vascular dementia.
Yeah. Well, again, now this is effectively, we're looking at a patient who's asymptomatic and is looking at prevention of cardiac disease. So what we look at are the risk factors in that particular individual and what the severity of each of those risk factors are. Now, a family history is usually defined as a cardiac event in a first-degree relative, a male under the age of 60 and a female under the age of 65. So if a parent has a cardiac event over the age of over those ages, then that's not considered to be a major risk factor for the individual concerned. Now we're talking, so then we look at the basic risk factors. We look at what their cholesterol level, the fasting cholesterol level is, what the blood pressure is there presence of diabetes, do they smoke, exercise, weight, they're the main ones. And if there's a particularly high level of any of those risk factors, then they have to be treated. And then we look at if they have moderately elevated cholesterol, moderately elevated blood pressure, there are scores that we can use to give us an evaluation of what their estimated risk is over the next 10 years. And that will then direct how vigorous we have to be in terms of addressing each of the individual risk factors. So family history, interestingly, is a funny one. Family history is not taken into account in many of these scores to much degree. And so we kind of have to fit it in or add it, if you like, to the risk factor profile of patients. So it can be a bit complex. For somebody that was mentioned here, I would have thought that the primary risk factors and the lifestyle change that are required would be to reduce weight primarily, and also to make sure that blood pressure and cholesterol are under control.
Okay, Jim, and do you have any thoughts on any of the other screenings that are out there? Because another query has come in relation to the calcification scan.
Yeah, this is a common question about the calcium. So there's two scans. One is the calcium score and one is the CT coronary angiogram. They're two different things. The calcium score is a part of the CAT scan, and they measure the amount of calcium that seems to be around the coronary arteries, which if they become blocked, cause the heart attacks. If there's a high calcium score, it gives an increased risk that the patient will develop coronary artery disease. The CT scan is actually a coronary angiogram. In other words, it looks at the artery itself and sees if there are any blockages in it. It's a reasonably good test for assessing whether the patient has coronary artery disease, has blockages in the arteries, or has none. It's a useful test like that. The definitive test would be the invasive coronary angiogram. But getting back to the calcium score, because this is the question that we're asked a lot, a calcium score is like looking at risk factors. If there's a high calcium score, what it tells us is that that patient is more likely to develop coronary artery disease in the future. It doesn't tell us that the patient has a blocked artery. It tells us that they're more likely. So it's like looking at another risk factor. It's like looking at high cholesterol. It's like looking at high blood pressure. And it can be particularly useful in people where they're considered to have a moderate risk of developing heart disease. So if they have a moderate risk of developing heart disease and we do a calcium score and we find that it's very high, then we know we need to be more rigorous about treating the patient's risk factors to reduce their risk of developing heart disease. While if they have a moderate risk of heart disease based on scores and all that, and their calcium score is 0, then we can say that they're probably less likely to develop coronary artery disease in the future. So it is a useful test in certain circumstances, but it's not the panacea or the big test that's going to tell us everything about risk factors. The risk factors are the ones that tell us about risk factors. So it's blood pressure, cholesterol, diet, weight, presence of diabetes, cigarette smoking habits. These are the ones that we know that if we alter will dramatically reduce patients' risk of developing a heart disease rather than the calcium score.
And of course, they account for the majority of cardiovascular disease
Absolutely.
as well. And all of these risk factors can be assessed by a visit to your GP or practice nurse, and they can do that risk, what we call a risk assessment with the individual as well, and predict your risk over a defined period of time. Now, I'm really conscious that we're at just gone past 10 to 8. And we promised that this session was only going to be for an hour. We could stay here all night because we've had so many questions coming in through the chat. But I'm just going to take one more question from the chat, and then we're going to look at wrapping up. And again, I think this is a very common question. And Jim, I'm going to come back to you on this one because it's something that we in Croí get asked all the time. And it's really about aspirin and aspirin for primary prevention. And the query here is aspirin for women over 70 years of age to prevent stroke, clots, heart disease.
Whether it should be used or not, taken or not.
Whether it should be used or not.
Yeah, for patients, for people who have no symptoms, have no indications, there's no indication to give aspirin. It should be given in patients where there are specific indications, and Cathy will probably talk about diabetes and all of that. But if a patient presents, has risk factors such as high blood pressure, such as high cholesterol and nothing else and no symptoms, then there's probably no indication for aspirin therapy. Now, obviously, if a patient has had a heart attack, we'll put all of those all those people on aspirin, and we'll also ask everybody who's had a stent put in, it'll be recommended that those people go on aspirin. As a routine drug for people who have no symptoms whatsoever or no indications, then it's not recommended.
Cathy, did you want to come in on the diabetes end of things?
In terms of aspirin?
Yes.
There used to be a vogue. If I had been a diabetologist 20 years ago, maybe 30 years ago, they would be a vogue for putting everybody and their mother on aspirin. We don't do that anymore. And a statin is the other thing. We don't routinely just hand it out to everybody with diabetes. We assess their other risk factors. If they've had a cardiac event, we think they're at extremely high risk of a cardiac event. But diabetes on its own does not merit aspirin or a statin. We would look at the cholesterol separately, but it would not merit it on its own. But it would have a number of years back. So there's people who historically are on it and have been left on it for that reason. But for people who develop diabetes, particularly type 2 or type 1, it's about any type of diabetes now, unless you have another significant cardiovascular risk factor, we don't put you routinely on aspirin because the side effects outweigh the benefits in that group. What you really need to do is control your diabetes, your blood pressure, the simple things, and do them well is what it's about.
Very true. Okay, so we're nearing the end of the session, and what I'd like to do by way of wrap up, because we've discussed so much on tonight's webinar, what I might do is ask maybe each of you just for your own take-home messages for our audience tonight, and I might start with you, Aisling, please.
Yeah, well, I think we've heard so much information and tips and advice tonight that my piece of advice would be to maybe pick 2 or 3 specific things that you want to focus on. Is it your salt intake? Is it the amount of fruit and veg you eat? Is it your portion size? Is it your exercise? Pick 2 things and focus on them. Just make it more manageable.
Cathy, how about you?
I would say keep it simple. I would say if you do not have diabetes, in order to prevent diabetes, look at your exercise, your diet, all the very, very common sense, the things your mom has been telling you for many, many years, the very simple things. If you have diabetes, the same applies. You watch your diet, you watch your exercise. I would say attend your appointments when they come up. If you have erectile dysfunction, if you're worried about it, if your partner has it, don't be afraid to say it. Say it to somebody, pick someone you trust and open that conversation up. You would be surprised how open we are to it and how much we can do about it. So I would say keep it simple and be open, and do attend your appointments regularly. Maybe my main take-home messages.
Yeah, I think that's a good point, Cathy, because I suppose, over the last 18 months, everything has been up in the air, and, lots of people haven't had the opportunity, to attend their appointments for lots of very, very good reasons and concerns that they've had. So that's an important one. Make sure that you do follow up with your GP and attend your hospital appointments. And of course, if you've any symptoms, don't delay. Jim, I might come to you.
Well, I was going to say attend your appointments. Make sure, when you get to, above your 40s, you should probably make sure that you know what your cholesterol is, know what your blood pressure is, so that if they need to be addressed, then they can be addressed. It's very easy to do. You check with your GP and they can do the basic measurements. I think the other thing is that it's just to remember that if you've had an event like a heart attack or a stroke or whatever, particularly for a heart attack, the goal, as I said earlier, is to get back to normal activity. And don't forget that that's where we want you to be. And that's where the vast majority of people will get back to fully normal activity, exercise, work, their social life, everything else. And that is the goal. So, people do get disheartened when they've had these events, and it leads them to not taking medications, to getting depressed, becoming, taken out of society in many ways. So it is to get back to normal activity, and that is the goal for the vast majority of people.
Yeah, absolutely, Jim. And I think, often people will say having an event has actually prompted them and given them a big nudge to doing things that perhaps they should have been doing prior to their event. And, I know from our experience in Croí delivering programs, lots of people will say that they are feeling better than they've ever felt before. And, that because they're leading a healthy lifestyle and making all the changes, they have renewed confidence. And that's so important after an event. And I know you mentioned about, the anxiety and depression earlier, but, all of those things can be addressed. And it's really important, to stay positive, but also to share your concerns with your family, and also to talk to your healthcare professional as well. Now, we weren't able to get through all of the questions tonight. But what we are planning on doing is we have a series of webinars that we're going to be doing like this. Many of these webinars will address some of the topics and questions that that the audience have raised tonight. We also have our dedicated telephone helpline, which you see on the screen at the moment, HeartLink West, and we do regular virtual health chats with all of the healthcare professionals, from consultants to dietitians, physiotherapists and nurses. So your questions, and we've made note of all of the questions that have been raised through the Q&A chat function, and we will address those queries through our virtual chats. The most important thing is that you're on our email distribution list, and I know you'll have been asked questions whether we can contact you about future events earlier, so hopefully you've ticked the box. Also, date for your diary. Our next session is going to be taking place on Thursday, the 20th of May. We're going to be talking about high blood pressure, and we have World Hypertension Day coming up. So it's a very, very topical, and we're doing a lunchtime seminar this time around. Often the evenings don't suit everyone. So we're going to try a lunchtime session. Okay, so finally, just to close out this evening, I would like to say a big thank you to all of our guest panel speakers, to Dr. Jim Crowley, to Aisling Harris, and to Dr. Cathy McHugh. Thank you for taking the time to join us this evening. Thank you to Sonchacare for supporting this event, and thank you, the audience, for joining us. We hope you found the evening beneficial. We hope you found it informative. We hope that we addressed many of your concerns and priorities. And I suppose finally, just keep in touch with us and keep engaged. And we look forward to seeing you soon again. Thank you and good night.